And as an overriding philosophy for the discussion that's going to ensue from here on out, I have a quote that I want to take from the AMA guides, and this is out of the AMA guides on page 493, which is actually out of chapter 16, and it's referring to cases of carpal tunnel syndrome. And you might be wondering, well, what's that got to do with the lower extremity cases? Well, it has a lot to do with it, because in chapter 17, the lower extremity chapter, and specifically the section dealing with peripheral nerve injuries, makes strong reference back to chapter 16. And as we go through our discussion here, we're going to refer back to some of the tables in chapter 16, and that's on the direct instruction of the AMA guides in chapter 17. So specifically, the AMA guides in chapter 17 advises us to consult tables 1610 and tables 1611, as well as other tables in chapter 16 to determine permanent impairments of the lower extremities in chapter 17. So really the two chapters kind of are analogous in the process and procedures involved for determining permanent impairments, regardless of where the peripheral nerve injury is, regardless if it's in the upper extremity or if it's in the lower extremities. So with regards to the upper extremity, there's a quote on page 493 that, in my opinion, will set the tone for the procedures that follow. And it says on page 493, and this is a quote, it says, "Only individuals with an objectively verifiable diagnosis should qualify for a permanent impairment rating. The diagnosis is made not only on believable symptoms, but more important, on the presence of positive clinical findings and loss of function." Unquote. So here the AMA guides give us our instruction that the diagnosis should be objectively verifiable, and that there should be positive clinical findings and positive demonstration of loss of function. And so far the bulk of this program has been all about describing the functions of these named peripheral nerves of the lower extremity and discussing the positive clinical findings that you could expect in the presence of a bona fide lesion of these named peripheral nerves of the lower extremities. So I think the AMA guides are telling us here that objective findings are paramount. And so as we think back over the program, let's think about some of the strong positive clinical objective findings that we could expect to see with peripheral nerve lesions. Well, certainly a gait disturbance, if it's a bona fide gait disturbance, that would certainly qualify as an objective finding. I mean, picture a high steppage gait due to common peroneal nerve injury, for example, at the fibular head. That's a strong objective finding. Atrophy of the abductor hallucis muscle due to a lesion of the medial plantar nerve. That is a strong objective finding. And so in order to qualify for permanent impairment, there needs to be strong objective findings. On page 493 it goes on to say that the diagnosis should be documented by electromyography as well as sensory and motor nerve conduction studies. And again, those are objective findings on which we can, upon which we can support a permanent impairment rating. Okay, so from chapter 16, let's fast forward now into chapter 17, and the AMA guides say here on page 550 that peripheral nerve injuries are divided into two components: motor deficits and sensory deficits. And we've spent quite a bit of time talking about sensory and motor functions of the named peripheral nerves. And the AMA guides talk about motor nerves as including the superior gluteal nerve, the inferior gluteal nerve, the nerve to the piriformis, and then from there it includes the obturator nerve, the femoral nerve, the sciatic nerve, and the medial and lateral plantar nerves. And we'll discuss the motor and sensory nerves as they're described in Table 1737 here as we go a little bit. And the guides go on to say that all estimates listed in Table 1737, which I've provided a copy for you both in the PowerPoint and in your handout materials, and that's also on page 552 of the AMA guides. It says that all estimates for permanent impairment listed in Table 1737 are for complete motor or sensory loss for the named peripheral nerves. Now, we're not often going to see complete motor or sensory loss, so the guides give us instruction on how to handle partial sensory loss and partial motor deficits. And it states that partial sensory and motor deficits should be rated as in the upper extremity as described in tables 1610 and 1611. So for you, those of you that have the handout materials, you want to reference here Table 1737. This is impairments due to nerve deficits, and this is found on page 552 in the guides if you're following along in your AMA guides. And interesting in this table that I want to draw your attention to is that this table provides permanent impairment ratings for loss of motor function, for loss of sensory function and or pain. Sensory function could be, or I should say that pain could be subsumed under the loss of sensory function of the nerve, and also provides for permanent impairment due to altered sensations, dysesthesia. So as you look at this chart, you'll notice that some of the nerves provide for 0% impairment due to loss of motor function. Why is that? Well, the reason that is because the nerves that have 0% permanent impairment due to loss of motor function are purely sensory nerves, including the lateral femoral cutaneous nerve, superficial peroneal nerve, and the sural nerve. Notice also that some of the nerves provide for 0% impairment due to loss of sensory function. And that would be the obturator nerve, the superior gluteal nerve, and then also the inferior gluteal nerve. Now, why would there be no permanent impairment due to loss of sensory function? Well, I referred to this a little bit earlier in the program, and that is, at least as regards to the superior and inferior gluteal nerves, those are motor nerves only. However, the obturator nerve, as we discussed earlier, does have a sensory function. It provides for sensation down at the medial aspect of the knee. However, according to this table, Table 1737, this table is telling us that the AMA guides do not ascribe much function or much impairment to loss of sensory function of the obturator nerve. In other words, here the guides are telling us that complete loss of function, which this table describes complete loss of function, complete loss of sensory function of the obturator nerve is not an impairment. It doesn't impair activities of daily living, and therefore it provides for 0% impairment in the presence of even severe pain or severe dysesthesia in the distribution of the obturator nerve. I find that interesting. And the AMA guides communicate to us through this chart their opinion of the relative impairments associated with both sensory and motor losses in each of the named peripheral nerves. Now the remainders of the nerves you can see are mixed nerves. They have both motor and sensory function, and the guides provide for appropriate losses of each of those nerves. The AMA guides refer us back to Table 1610 to determine partial sensory losses, and I just want to go over a couple of important factors about this table. This is Table 1610, and this is out of the upper extremity chapter, but we are mandated by the guides to use this table also in determining impairments of the lower extremities. And here the classification system goes from a grading of 5 to a grading of 0, with a grading of 5 basically indicating normal function, and a grading of 0 basically indicating an absence of function. And if we go through the definitions of each of these gradings, I want you to mentally think as to which grading describes the majority of the examinees that we are going to encounter. So grading of 5 describes no loss of sensibility, no abnormal sensation, and no pain. Well, that's basically a normal person. That's a person who's coming in and really is not describing any subjective complaints. They have no pain, no abnormal sensation, and no loss of sensibility. Well, that person has normal sensory function of the peripheral nerve, and so therefore they do not qualify for any permanent impairment. A grading of 4 provides for 1 to 25% loss of function of the sensory nerve, of the named peripheral nerve. And the definition of a grade 4 is that there is distorted superficial tactile sensibility, meaning there's diminished light touch sensation. So how would that manifest by clinical exam or in the physical exam? That would manifest in the physical exam by diminished response to monofilament testing. Your 2.61 monofilament, your smallest monofilament, might not be large enough or stout enough or create enough of a depression in the skin to fire the subcutaneous sensory receptors. You may have to use the next larger monofilament, or even the next one larger than that, in order to create enough pressure to create enough deformation of the multilaminar encapsulated receptors to get them to fire. So that would be an objective finding that you would determine, for example, with use of your monofilaments. So there's diminished light touch. There may or may not be abnormal sensations or pain. Or, if there is pain, pain is mostly forgotten during activity. And for those of you that have a few years on you, I like this definition from the AMA guides because it roughly parallels older definitions of pain that we used to use when using the Permanent Disability Rating Schedule, the 1997 Permanent Disability Rating Schedule. This sounds a lot like what we used to call minimal pain. Minimal pain is pain that does not interfere with activity. And here with a grade 4 pain grading, the pain does not interfere with activity. So in that sense, the pain is largely subjective. It doesn't interfere with activities or activities of daily living. However, because of the presence of some positive objective findings, meaning a finding of diminished light touch, the AMA guides does provide for some level of permanent impairment due to loss of sensory function. A pain grading of 3 is defined as diminished light touch and diminished 2-point discrimination. And as I said, we do not perform 2-point discrimination testing in the lower extremities. This is out of the upper extremity chapter, so we disregard that part of the definition. So we have diminished light touch, we have some abnormal sensations, or slight pain that interferes with some activities. And again, this definition is consistent with the 1997 Permanent Disability Rating Schedule, wherein we described slight pain. And slight pain is pain that slightly interferes with the performance of some activities. And the AMA guides are all about activities of daily living. So in your assignment of a grade 3 rating for loss of sensory function should correspond to similar findings on an activities of daily living assessment. And specifically now, since we're talking about activities of daily living as involves the lower extremity, the AMA guides describe on page 4 general categories of activities of daily living, such as personal care and self-hygiene, communication activities, travel activities, sexual activities, physical activities, etc. You might think to yourself now, okay, well, which of those activities of daily living that are described on page 4 would most likely be affected with loss of sensory function of the peripheral nerve? Well, the AMA guides provide for 0% impairment for complete sensory loss of function of the obturator nerve. Now, some of the other nerves, they are providing for some degree of permanent impairment, but it's small, and through these calculations, the AMA guides are telling you that loss of sensory function, at least around a grade 3 level, does not significantly interfere with activities of daily living. I mean, what could it interfere with? Could it possibly interfere with gait? I guess it could, because we need the tactile sensations in order to properly coordinate gait. But we're probably not going to have a lot of interference with gait with a grade 3% sensory deficit. And I don't want to belabor the point, but continuing down the chart, and you can read the definitions from table 1610, describes increasing loss of sensory function of the peripheral nerve root. And I have not seen any of these particular cases in my examinations of injured workers. I've never seen a person with a grade 0 who had complete absent sensibility or had severe pain that prevents all activity. So most cases are probably going to be a grade 4 and or a grade 3. Anything beyond a grade 3 down into a grade 2 and a grade 1 is going to be accompanied by significant additional objective findings, perhaps even to include the need for an assistive device, because as we're talking here about the lower extremities, a grade 2 classification by definition involves abnormal pain. Includes abnormal sensations or moderate pain that may prevent some activities. So what activities are the lower extremities involved with? Well, primarily they're involved with ambulation, for example. And so if ambulation is prevented, we would certainly expect to see probably some type of an assistive device, maybe crutches, maybe even a wheelchair. So that's a little bit of insight as to how to look at Table 1610. Similarly, Table 1611, we use Table 1611 to determine impairment due to motor loss or power deficits in the lower extremities. And in this case, the grading system goes from grade 5, which describes a completely normal examinee, an examinee that has full range of motion against gravity and with full resistance. So let's think about this. With regards to the lower extremity, where is there full resistance? Well, there's full resistance in resisted hip flexion. There's full resistance in resisted hip adduction. There's full resistance in resisted knee extension, resisted ankle plantar flexion, resisted ankle dorsiflexion, resisted great toe extension, and all the manual muscle tests that we described for the lower extremity. It indicates that this person is completely able to perform the heel walk and toe walk maneuvers. They're completely able to perform the repetitive squat maneuvers. Basically, this is a person that has full motor function. And then from there, the AMA guides provide for increasing permanent impairment based upon decreasing muscle function. And most cases, in the presence of a motor deficit, most cases will qualify for a grading of a grade 4, meaning that they have full range of motion, but they're only able to provide some resistance, not full resistance, but some resistance to manual muscle testing. Below grade 4, we see increasing loss of function, which is obviously going to severely impact activities of daily living, severely going to impact ambulation, and would certainly be accompanied by other objective findings, including atrophy, perhaps need for an assistive device, perhaps need for an ankle-foot orthosis, perhaps needing a foot prop-up brace in the case of a foot drop. In other words, lower gradings should be accompanied by significant other objective physical exam findings. Okay, on page 552, the AMA guides instruct us that estimates for peripheral nerve impairments may be combined with those for other types of lower extremity impairments, except those for muscle weakness, muscle atrophy, and gait derangement. Why do the AMA guides not allow peripheral nerve impairments to be combined with impairments for muscle weakness, muscle atrophy, and gait derangement? Well, the reason is that would be a duplication of impairments, because peripheral nerve lesions cause muscle weakness, cause muscle atrophy, and can cause gait derangement. So if we look at Table 17.2, the guide to the appropriate combination of evaluation methods, if you locate peripheral nerve injury across the top and then just scan downwards, you'll notice the columns marked with X includes gait derangement, includes muscle atrophy, and includes muscle strength. Those are the impairments that the AMA guides do not allow to be combined. Now, unlike the upper extremities, the lower extremity impairments due to peripheral nerve injury can be combined with impairments due to loss of range of motion, and that's a different that's a different combination than we are allowed with the upper extremity. So a little bit more application, a little more liberal application of permanent impairments here for the lower extremity. We're also allowed to combine impairments due to post-traumatic arthritis, due to amputation. We're allowed to combine with any of the diagnosis-based estimates. We're allowed to combine with any permanent impairments due to skin loss. And this might be an area where you can provide additional permanent impairment for any trophic changes that you find as a result of disruption of the autonomic supply of any of the lower extremity peripheral nerves. So that is an area where you can creatively analogize if you find that to be appropriate. Finally, the guides allow us to combine impairments with peripheral nerve injury with other impairments related to vascular injury of the lower extremity. Okay, so let's get into the procedure that the AMA guides require. This is described on page 550 of the guides if you want to follow along. First step is to identify the injured nerves. Identify the injured nerves, and you determine if there's a sensory injury or a motor injury, or if there's both sensory and motor injury. In the presence of a motor nerve deficit, you grade the severity of the motor deficit. And we just went over the different severities of motor deficit. That comes from table 1611 out of the upper extremity chapter. That's on page 484. And this is exactly the same procedure that we use for the upper extremity. Now, values of the severity of motor deficit range from 0, meaning no deficit, to 100% motor deficit, wherein there is no evidence of contractility at all of the muscle. In the presence of a sensory deficit, we then use table 1610A on page 482, and again, this is from the upper extremity chapter. And we just went over this table. Values here range from 0, meaning that there's completely normal function, to 100%, which is complete loss of all sensibility or severe pain. And remember that severe pain is pain that prevents all activity. So I don't know how many cases of severe pain you've ever seen, but it's probably few. Then, once we have the severity of sensory deficits, we combine the sensory impairments with the motor impairments for nerves with motor and sensory fibers. Or in the case of multiple nerves, we combine the sensory and or motor impairments of one nerve with sensory and or motor impairments of another nerve in the event of multiple nerve involvements. And I want you to note that unlike the upper extremity chapter, in chapter 17, table 1737, that describes the permanent impairment ratings for sensory losses and motor losses, already contains the conversion to whole person impairment. And that's different than chapter 16, where we first determine an upper extremity impairment value and then later have to convert that to a whole person impairment value. Table 1737 already has done that conversion for us. Okay, so those are the general steps involved. So let's take a look at this now from a slightly deeper level and in a little bit greater detail. So steps 1 and 2 are to identify, first of all, the area of involvement. And figure 17.8 gives us the general areas of involvement where we can start to localize our focus. Then once we have the area of involvement, we can identify the nerve structure or structures that innervate that area. And sometimes there are multiple nerve structures innervating certain areas. For example, in the anterior aspect of the lower extremity, we have portions of the lateral femoral cutaneous nerve, the genitofemoral nerve, the femoral nerve, the obturator nerve, the lateral sural cutaneous nerve, portions of the saphenous nerve, and even the superficial peroneal and deep peroneal nerves all have twigs that contribute to sensation to the anterior aspect of the lower extremity. For the posterior aspect of the lower extremity, we have the femoral nerve, the posterior femoral cutaneous nerve, the lateral femoral cutaneous, the obturator, the saphenous, the sural, and the superficial peroneal. So you can start to see that there's a lot of overlapping of sensory areas and even sensory nerves. And then down in the foot, we have the sural nerve contributes to sensation of the foot, the saphenous, the medial plantar nerve, the lateral plantar nerve, and the medial calcaneal nerve. So it's up to you, doctor, to determine which nerve you think most appropriately is involved or most appropriately describes the area of involvement that your examinee is reporting. Once you've identified the area of involvement, then you have to use Table 1610A on page 482, and again that's in Chapter 16, to grade the severity of the sensory deficit or the pain. And I think we've gone over Table 1610A in sufficient detail. Just a couple of final comments about Table 1610A, at least as relates to the lower extremity, and that is that for a grade 3 with a 26 to 60% sensory deficit, Table 1610A describes some loss of 2-point discrimination, and actually we don't test for 2-point discrimination in the lower extremity, so that portion of the definition of a grade 3 sensory deficit does not apply in the lower extremity. And then remember what we said earlier about how this pain interferes with activity, and specifically with activities of daily living when it comes time to assign your percent of sensory deficit. And in fact, most of the sensory deficits, even a 100% sensory deficit or even severe pain, does not qualify for much, if at all, permanent impairment, at least as relates to percent of sensory deficit. Then, once you've determined the severity of the sensory deficit, you then go to Table 1737 to determine the maximum lower extremity impairment value for the particular nerves involved. And you go right down the sensory column, which is the middle column, and determine the maximum maximum whole person extremity value. And you'll notice in Table 1737 it already contains the whole person impairment conversion factor. So for example, the superficial peroneal nerve, if you had a complete loss of sensory function of the superficial peroneal nerve, that qualifies for 2% whole person impairment. Why would that be? Because that would involve either complete loss of sensation or severe pain in the top of the foot that prevents many activities of daily living. And what types of activities of daily living rely on the foot? I guess this would include mostly ambulation, and I guess severe pain could interfere even with, I guess, mostly ambulation. Would you agree? Okay, so that's step 4, is to determine the maximum lower extremity impairment value for the particular nerves involved. The femoral nerve has a maximum whole person impairment value of 1. Lateral femoral cutaneous nerve has a maximum whole person impairment value of 1. Common peroneal is 2. Superficial peroneal is 2. Sural is 1. Medial and lateral plantars are both 1. The highest impairment value is provided for the sciatic nerve because of its greater distribution and therefore its greater impact on activities of daily living. And in your handout materials, I've created a chart for you that lists all these nerves from table 1737, but I've categorized them into 3 columns to distinguish the nerves that are sensory nerves only, the nerves that are motor nerves only, and then those nerves that have both combined sensory and motor impairments associated with them. So nerves with sensory impairment only include the lateral femoral cutaneous, the superficial peroneal, and the sural nerves. Nerves with motor impairment only include the obturator nerve and the superior gluteal nerve and the inferior gluteal nerve. Those are nerves for which the AMA guides provide for only motor impairment. The AMA guides provide for sensory and motor impairment for the femoral nerve, for the sciatic nerve, for the common peroneal nerve, for the medial plantar nerve, for the lateral plantar nerve. And what's interesting is if you take a moment and look at this chart, and if you go back over the material that we've discussed so far, we have stated that the obturator nerve is both a sensory and motor nerve. There is a small sensory component to the obturator nerve. We talked about the sensation to the medial knee area being provided for by the obturator nerve. Similarly, the superficial peroneal nerve is a motor and sensory nerve. It provides for motor supply to the peroneus longus and peroneus brevis muscles. However, the AMA guides do not provide impairment for loss of function of the superficial peroneal nerve. So, considering the obturator and the superficial peroneal nerves, the AMA guides do not provide impairment for total loss of ankle eversion through the peronei muscles due to damage to the superficial peroneal nerve. Similarly, the AMA guides do not provide impairment for total loss of sensation due to the medial knee due to loss of function of the obturator nerve. So this gives us some indications as to the AMA guide's position on the role of ankle eversion in activities of daily living. Similarly, the AMA guides don't provide for any impairment due to loss of sensation to the medial knee because that apparently, in their opinion, has no impact on activities of daily living. Okay, so once we've identified the maximum impairment value of each of the nerves involved, we then go on to step 5. Step 5 is to multiply the percentage of severity deficit, and remember that severity of sensory deficit comes from table 1610A, We then multiply that by the maximum whole person impairment value that we discovered in table 1737, and this gives us the final whole person impairment due to sensory deficit. And we simply repeat this procedure for each of the nerve structures involved, and we record our numbers. Then we repeat the procedure for grading the motor deficit. Steps 1 and 2 for grading the motor deficit are the same as those for determining the sensory deficit, and that is, number 1, you have to first identify the motor deficit. What is the motor deficit? Is there a loss of hip flexion? Is there weakness in knee extension, hip abduction, etc.? Once you identify the motor deficit, you then have to identify the injured nerve that is responsible for that deficit. Then, for the upper extremities, we use table 1612 to determine which muscle is weak, and therefore to determine which nerve is involved. Now, we have no such table in chapter 17. Therefore, we use the following table, and I've provided this table for you in your handout materials and also in the PowerPoint presentation. Okay, and I created this table for you, and it's in your handout materials. One of the differences between chapters 16 and chapter 17 is that chapter 16 provides us with a table that relates muscles to the nerves, so that if we find a muscle weakness, we can simply use the chart to assign the appropriate nerve to that muscle. We have no such table in chapter 17, so I created a table for you for easy use. So if you find weakness in number 1, either resisted knee extension and or 2, resisted hip flexion, that's associated with the femoral nerve. Weakness in resisted hip adduction, AD-deduction, that's associated with the obturator nerve. If you have weakness of resisted hip abduction by manual muscle testing, that's associated with weakness of the gluteus medius muscles, the gluteus minimus muscle, and the tensor fascia lata muscles, which are associated with the superior gluteal nerve. Now, another sign of injury or damage to the superior gluteal nerve is what's known as a Trendelenburg sign. So, with weakness of the gluteus medius, with the hip or the pelvis unstabilized, we will notice weakness in resisted hip abduction. However, when the hip joint is fixed, for example, when the examinee is walking, weakness of the gluteus medius muscle will manifest as loss of stabilization of the pelvis in the coronal plane, meaning that the pelvis drops opposite the weight-bearing sign, and we know this traditionally as a Trendelenburg sign. Also, a physical examination finding for weakness of the gluteus medius muscle, perhaps due to a superior gluteal nerve injury. And recall that the superior gluteal nerve is a named peripheral nerve of the sacral plexus that arises from the dorsal divisions of L4, L5, and S1 prior to the formation of the common peroneal nerve, meaning that it comes off of the sacral plexus prior to the entrance zone of the S2 and S3 nerve roots. So it indicates a rather high lesion in the pelvis. So weakness of the gluteus medius may manifest either as weakness to resisted hip abduction by manual muscle testing, or also in observation as the Trendelenburg sign in the case of a unilateral lesion. In the event of a bilateral lesion, we notice that the examinee has what's called a waddling gait. Waddling gait is what we call bilateral weakness of the gluteus medius muscle. If we have weakness of the gluteus maximus muscle, in other words, in physical exam, we notice that there's weakness of resisted hip extension by manual muscle testing, or by observation when the hip is fixed, we notice a loss of sagittal plane stabilization of the pelvis. Sagittal plane, it's the gluteus maximus that stabilizes the pelvis in the sagittal plane. It's the gluteus medius that stabilizes the pelvis in the coronal plane. And so this creates a gait disturbance known as the gluteus maximus lurch, which the gluteus maximus lurch is a compensation for lack of hip extension during the stance phase of gait due to weakness of the gluteus maximus, which is associated with the inferior gluteal nerve. The inferior gluteal nerve. And the inferior gluteal nerve is a named peripheral nerve of the sacral plexus arising from the dorsal divisions of L5, S1, and S2 prior to the entrance zone of the S3 nerve root. So the superior gluteal nerve comes from the L4, L5, and S1 nerve roots. The inferior gluteal nerve comes from L5, S1, and S2. So weakness here would indicate a slightly lower lesion, but still a high lesion relatively high up into the pelvis. And so far in this program, we've already discussed at length muscle weaknesses related to the tibial and common peroneal divisions, referring to all the muscle innervations above the knee, including the semitendinosus, the biceps femoris long head, the semimembranosus, and the adductor magnus being associated with the tibial nerve, and then all innervations of the tibial nerve below the knee, excluding the foot. Those are associated with the sciatic nerve. And then we've already discussed all of the muscle weaknesses associated with the common peroneal nerve as well. And my final comment regarding the common peroneal nerve is that in Table 1737, the AMA guides break out the common peroneal nerve and provide for permanent impairments due to injury to the common peroneal nerve separate from impairments related to the sciatic nerve. So based on that and based on the material that we've discussed so far, it appears that the AMA guides provide for impairment for weakness of all innervations of the common peroneal nerve, including the short head of the biceps femoris, the tibialis anterior, the peroneus longus, the peroneus brevis, the peroneus tertius, and the extrinsic muscles of the toes and the great toe, including the extensor hallucis longus and the extensor digitorum longus. Finally, down into the foot, weakness of the adductor hallucis, the flexor digitorum brevis, the flexor hallucis brevis, the first lumbrical. All of those muscles are associated with the medial plantar nerve. And you'll recall that the adductor hallucis is involved with big toe abduction. The flexor digitorum brevis is involved with flexion of the proximal phalanxes, proximal phalanges of toes 2 through 5. The flexor hallucis brevis is involved with flexion of the proximal phalanx of the big toe. And the first lumbrical is involved with flexion of the second metatarsal phalangeal joint with extension of the second toe interphalangeal joint. All of those muscle weaknesses basically all muscles on the sole of the foot that go to the toes, including the big toe, are associated with the medial plantar nerve. And then finally, weakness of abduction of the little toe, associated with the abductor digiti minimi. That's associated with the lateral plantar nerve. Okay, so once we've identified the associated nerve from table 1737, we can then go on to step 3. And step 3 requires that we grade the severity of the motor deficit of each of the individual muscles involved. And in order to do this, we go back to chapter 16, table 1611, and we've described this table already at length. We stated that most impairments will fall in the range of either grade 5 normal or grade 4, indicating that there is some loss of strength, which provides for a wide range of preserved function. Okay, so we take the percent motor deficit from table 1611. And in reference to table 1611, the AMA guides gives us some instruction. And this is found in chapter 16 on page 484. And speaking specifically about table 1611, the AMA guides state the following, and this is a quote. It says, "The examiner must use clinical judgment to estimate the appropriate percentage of motor deficits and loss of power within the range of values shown for each severity grade." So, for example, the severity grade of grade 4 provides for a range of motor deficit from 1% all the way to 25%. So it's up to us as doctors to determine where in the range we estimate the motor deficit to be. Okay, so let me continue from the AMA guides. It says that it's important to ascertain that weakness is due to loss of nerve function before using these tables. Weakness may be due to many causes, including pain, and table 1611 is not to be used for rating weakness that is not due to a diagnosed injury of a specific nerve or nerves. A diagnosis of nerve injury can usually be made by a careful physical exam done by an examiner who has sufficient knowledge of the anatomy and function of the part. The AMA guides go on to state, note that grade 4 covers a wide range of weakness, from minimal detectable weakness to severe weakness, in which the muscles are functional through a full range with only very slight resistance. The degree of weakness should be rated from 1% to 25%, depending upon the degree within this grade. So, doctors, I simply reiterate here that in the presence of motor weakness, most motor deficits will be assigned a grade 4. Any lower grade ratings, such as a grade 3, grade 2, grade 1, are going to be accompanied by significant additional objective findings, including possibly gait disturbance and at least probably a need for some type of an assistive device. Okay, so then we go on to step 4. We then determine the maximum whole person value for the particular nerves involved due to motor deficit, and we go back to table 1737 for this. And reading directly from table 1737 with regards to, for example, the superior gluteal nerve, complete loss of function of the superior gluteal nerve provides for 25% whole person impairment. Now think about that. That's a substantial impairment. That gives you an indication of the importance of the superior gluteal nerve in performing activities of daily living. And you'll notice that according to Table 1737, there is no sensory impairment provided for damage to the superior gluteal nerve. It's simply for the loss of function, particularly in ambulation, that results from an injury to the superior gluteal nerve. And referring back to our chart, we have, again, nerves with motor impairment only include the obturator nerve, the superior gluteal nerve, and the inferior gluteal nerve. And the nerves that have combined sensory and motor impairment include the femoral nerve, the sciatic nerve, the common peroneal nerve, and also the medial and lateral plantar nerves. So once we've identified the nerve structure involved and determined the maximum impairment available for that nerve, we can then go on to step 5. Step 5, we multiply the percent severity of the motor deficit that we determined in step 3 by the maximum impairment value that we determined in step 4, and this gives us the whole person impairment value due to loss of motor function of the involved nerve. And in the case of multiple nerve involvement, we do this for each nerve structure involved and record our numbers. Finally, we then combine the sensory impairments and the motor impairments. We use the combined values chart on page 604 to combine sensory impairments and motor impairments for nerves with motor and sensory fibers. Or in the event of multiple nerve involvements, we combine the sensory and or motor impairments of one nerve with the sensory and or motor impairments of another nerve to come up with a final whole person impairment due to peripheral nerve lesion. So that gives us the final whole person impairment due to the combined effects of sensory and or motor loss of one or multiple peripheral nerve lesions. Then, in the event of other impairments, and we discussed some of the other impairments that can appropriately be combined with peripheral nerve lesions, including vascular injury, including loss of range of motion, and others from Table 17.2, we combine those other impairments with impairments due to peripheral nerve lesions, again using the combined values chart and with specific reference to Table 17.2, the appropriate combinations chart for combining lower extremity impairments.